Thank you for the introduction. Today's topic is going to be a performance comparison of the Bruker MBT Sepsityper for culture-independent identification and direct antimicrobial susceptibility testing from positive blood cultures. My name is Lindsey Singer, and I want to thank my collaborators who worked alongside me for this project. My main advisor is Dr. Pandey and Ken Oliveira from Bruker, and just a big thank you to them for making all of this possible. So I want to talk about a little bit of a background on bloodstream infections. So BSIs affect approximately 1.7 million adults in the United States each year, and they contribute to more than 250,000 deaths. Various studies estimate that sepsis is present in 30 to 50% of hospitalizations that culminate in death. And unfortunately, BSI is the most expensive condition to treat, with a total of about 15 billion, or 4.3% of all costs. This is why it's important to emphasize the significance of antimicrobial therapy. So effective and timely antimicrobial therapy is crucial for patient survival of bloodstream infections. For each hour of delay during the subsequent 6 hours, the chances of survival decreases by 7.6%. And these graphs just illustrate, what I have mentioned so far. So the time from onset of symptoms or hypotension onsets, as that goes on, your percent fraction of survival ultimately decreases. So let's talk about a blood culture workflow. So there's 3 main components that take place for a blood culture. First, you have your pre-analytical portion, which is timing of the patient. What are their symptoms? Do they need a blood culture? Then blood is drawn and it gets transported to the lab. Ultimately, it gets seated in usually an incubation type of instrumentation. At my hospital, we use the BACTEC system. And when it flags as positive, it gets a gram stain, leading to culture for organism ID and susceptibility testing. And the post-analytical portion is notification to the physician and primary team, reporting all results, and ultimately consultation and determining how we're going to treat the patient. Blood culture guidelines were established by the CLSI M47 document, and it contains all of the procedures necessary to follow a blood culture. So this is basically what I had mentioned, but I just want to focus a little bit on the analytical section here. You have a suspicion of sepsis, then you get the blood bottle collection, followed by incubation. Then you have a positive blood culture alert, and this is where I want to, key in my focus here. We want to see, how long and, how fast we can get our results to our patients, meaning to the doctors taking care of our patients. So at this point, there are many rapid methods that have been established, and I'll discuss more of this on my next slide. We have PCR methods, etc., that are working to give rapid identification. But not everything is, as, efficient as a full blood culture result. So let's focus on the next slide here. So a word on some rapid methods. They allow identification directly from a positive blood culture. Some examples include a PCR-based approach, such as the FilmArray BCID. You also have microarray-based approaches. And, ultimately, there's many limitations. You have species coverage can be insufficient, and most will provide information regarding organism identification and drug-resistant markers to initiate treatment, which is still very important, but a full blood culture workup will still require about 48 hours. So I want to focus my attention towards the Bruker MBT Sepsityper kit. It is a MALDI Sepsityper kit that is qualitative in vitro diagnostic device intended for use in conjunction with other clinical and laboratory findings to aid in ID and differentiation of bacterial and fungal infections from positive blood cultures. It's used with the MALDI Biotyper CA system and consists of the Sepsityper kit, and the Sepsityper software, which is an FDA-approved reference library for organism identification. This kit is super important because it allows identification of microorganisms within 15 to 20 minutes with hands-on time of about 10 minutes, making it a very fast and easy process to aid in the care of patients with sepsis and provide, results to physician in a timely manner. So a little bit how this works, it's using the MALDI system, which is a mass spec-based instrument, and it results in log score values that are ultimately used to determine if we can release an organism identification or not. So Bruker has established that a score of 1.8 and higher is considered a high confidence score. And if you get an ID within this range, it is acceptable to be released to the physician. 1.6 to 1.79 is in the low confidence range. You might want to repeat the test or do their extraction method. And less than 1.6 will ultimately lead in no organism identification possible. So there's been a lot of use of this Sepsityper kit. There was a meta-analysis of 21 different studies that have investigated in the performance of this kit. I want to mention it's only used for monomicrobial blood cultures, so any polymicrobial blood culture sets you can't use on this for use with this kit. But based on other studies, we've had about 90% of total gram-negative bacteria being identified, 76% out of 2005 gram-positive bacteria were identified, and about 66% of a total of 188 positive yeasts were identified. So people are having, some pretty successful results with the Bruker kit. And generally, the Sepsityper performs better with gram-negative compared to gram-positive and yeast. So I want to now focus on how I did a Sepsityper evaluation at Westchester Medical Center. So let's look at the left here. You have a positive blood culture that gets flagged in the laboratory. At Westchester, if this is from a new patient, we will perform a PCR-based molecular assay for timely identification. This takes about 2 hours. With that, the blood bottle is also set up to get the full blood culture. This means a gram stain result and inoculation of culture media to be read at 2 incubation periods. Once we have some growth, we're able to ID it using the MALDI system, and we do sensitivity using the Beckman Coulter microscan. At the top, it shows the timeline, which takes about 48 hours for full sensitivity results to be reported to the physician. But how long would it take if we were to use the Sepsityper kit for ID, and then even maybe take it a step further to see how soon we can get direct antimicrobial susceptibility results, all from the Sepsityper kit? So I'm going to list my objectives here. We're going to compare the accuracy of the MBT Sepsityper kit for bacterial identification directly from a positive blood culture to the standard of care. I want to determine if the bacterial pellet generated from the Sepsityper kit can be used to determine antibiotic susceptibilities for gram-negative bacteria, and determine the time to final blood culture results using the Sepsityper kit versus the standard of care methods. So during this study, 130 blood cultures were used that were collected at Westchester Medical Center. I processed the blood cultures in a batch system, and they were all done within 24 hours of the bottle flagging positive. Bacterial extraction was performed per the Bruker Sepsityper protocol, and the ID was made by the MALDI Biotyper system. I then set up antimicrobial susceptibility for 50 blood cultures with gram-negative bacteria using the remnant bacterial pellet directly onto the microscan instrumentation. I compared these results for essential and categorical agreement. And the time from positive blood culture gram stain results to final blood culture report was calculated for 20 cultures. So this diagram illustrates how the Sepsityper kit is used. I won't get into too much detail, but basically you have a positive blood bottle and you pour a portion of it into a tube, and lysis buffer gets added, followed by a washing step, and ultimately you get a bacterial pellet that's generated at the bottom of the tube. Then you're able to spot this onto a MALDI-TOF target, just like you would for a direct colony usage from a plate, and run it using the Sepsityper software on the MALDI. It's recommended that you use 2 spots, one with formic acid and one without. And if you are unable to get an ID or a score that is not high enough, you can perform their standard protocol, which is a full extraction method, which I have used myself and it was successful as well. So a little bit about the performance. I ran 130 bottles on this kit and 95% of them yielded an ID of any score. I had 92 bottles that had a score greater than 2.0, and the reason I mention this value is because at Westchester, they only release a score if it has a log score of greater than 2, but that's not really necessary in terms of the Sepsityper protocol. Jumping down, there were 14 bottles that were in that low range, and only 7 out of the 130 failed to give an ID, and though the names of those isolates are listed to the right, I had 3 gram-positive organisms and 4 gram-negative, 2 of which were anaerobes. So I wanted to see if I got a low score value, was the identification still accurate? And as you can see here, the 14 are listed to the right, and there was 100% agreement for the species level ID between the 2 methods, the Sepsityper and the ID from the standard of care. So like I mentioned, I did 50 gram-negatives for an AST comparison. So in order to be chosen to be run for the AST, I had to have a identification on the MALDI that was a gram-negative organism, and there had to have been enough pellet generated at the bottom of the tube to be used in this step. Dilution tubes were inoculated using that bacterial pellet, and this was all using the Microscan and M45 panels, all based on their manufacturer recommended protocol. To the right shows a little bit about the setup here. For those that are not familiar, the Microscan involves, dilution trays. So you have to inoculate a prompt bottle and then pour this in and inoculate a tray, which gets incubated in the machine. 21 antibiotics were assessed in this study. For the comparison, I used the CLSI M52 document, and I went through and I wanted to see if I would match, the acceptance criteria for both essential and categorical agreement. So I'll just define these for those who are not familiar here. So in order to be an essential agreement, the percent of isolates producing MICs must be within 1 doubling dilution of the standard method. So that's one portion that needs to, be met in order to be, acceptable by CLSI. The next portion is your categorical agreement, and that's all based on interpretation. So it's based on the percent of isolates producing the same category of results, such as susceptible, intermediate, or resistant, and basing it or comparing it to the standard method. So this breaks down further into 3 types of errors. You have your minor, major, and very major errors. So the minor is the least detrimental effect on the therapeutic decision. It's when run, one form of the test gives you an intermediate result and the other is sensitive or resistant. Your major error is when you're getting a resistant result on the test method, in this case, the Sepsityper in conjunction with microscan versus sensitive by reference method. This isn't the worst, but it can be a serious consequence if therapeutic options are limited. Your very major error is the most serious. It's when you're saying an antibiotic can be utilized or it's sensitive to a drug, and it actually is resistance by the reference method. So in that case, the method failed to detect the resistance, and it can result in ineffective therapeutic agent for treatment of infection. So I won't go into too much detail here, but these were the calculations that I used. It's all in the CLSI documentation, and this is how I produced the results on the next page. So this graph here shows, or this table shows, my direct antimicrobial susceptibility performance. On the left, you see the 21 antibiotics that were used in this study, and the top shows the different categories that CLSI establishes. So the first column here shows your total eligible isolates, which means how many of the organisms that are run, had a result for the antibiotic listed. So for an example, amikacin at the top had 49 eligible isolates, for that drug. Now we go further to the right and you have your essential agreement. So how this graph works is, there were 49 eligible and all 49 fell into essential agreement. And the next one would be your categorical agreement. And here we had all 49 of them matching in categorical agreement, so there were no errors. But to give an example of one that did not have everything, within 100% match, let's see, cefazolin, it had, 43 that were eligible for the study, and 42 of them were in categorical agreement, which means that we would have one type of error. And if you look down to the right, that would be your very major error, and there was one isolate that gave a very major error. I know off the top of my head that this one was an E. coli. So like I said, we really want to avoid these very major errors. Maybe if this were to be implemented, we would have to, suppress this antibiotic for E. coli if it was being released. At the bottom shows the averages for each category here, and to the right shows the acceptable rates by CLSI, and everything, matched the expectations in order to be, used for direct AST. So let's talk about the impact of the MBT Sepsityper on time. So I wanted to see if we were to use this kit and, use it alongside the microscan system, how much time are we saving? So I looked at 20 blood cultures because they best represented the data. They were set up, in a time most similar to when it flagged positive. So what I did is I used the gram stain as the base time. So I looked at what time was the gram stain released by the technologist and what time was the sensitivity released. So I calculated that total time, and then I compared it to the gram stain time and to the time that I reviewed the antibiotic results. So you can see here that using the Sepsityper kit in conjunction with the microscan, it saves about 30 hours in comparison with a routine culture, which takes approximately 52 hours, and typically, it's about 48 hours. And I do want to mention, I didn't mention this earlier, that I only looked at gram-negative organisms because a lot of the gram-positive tend to be contamination or coag-negative staph, and there wouldn't be many susceptibility reports listed to compare. In conclusion, this is the first study to perform a comparison of direct AST for positive blood cultures containing monomicrobial gram-negative organisms with this type of instrumentation. The MBT Sepsityper identified 94.6% of isolates with 100% concordance to the culture-based method. A main source of error was a lack of pellet formation. If, it wasn't abundant, it was difficult to spot on the MALDI target, and also it would be difficult to use, the pellet for both steps of the study. I didn't see a difference for the Sepsityper's ability to identify gram-positive versus gram-negative bacteria. Overall, I had a pretty good success rate for both. And these are all things that I mentioned before, that the acceptance criteria was all met for the CLSI criteria. And some other sources of error were high pellet intake when inoculating the prompt dilution tube. It would be nice to determine a standardized way to make sure that we're not, putting too much bacteria into that dilution tube. Another main problem was interfering particles such as inclusions of red blood cells or even the bottle beads that were able to surpass the needle when extracting the blood. Another thing is that sample size plays a significant role when calculating your major and very major errors, because it's all based on dividing the total number of isolates. So with greater sample size, these numbers for my major and very major error may have gone down. The turnaround time in comparison for the Sepsityper and the final blood culture reports for standard method was 52 hours versus about 22 hours, saving about 30 hours. And some important considerations would be batching and microbiologist availability 24/7. We would need to determine a way how would, this be run in a lab, because it's not going to be where a bottle that's flagged and this whole, procedure can be underway. It would need to be batched, which ultimately, could affect the notifications of results. How soon are we getting them to the physician? I have mentioned all of these before, so I'll just leave them here to view. But important thing is that cultures containing polymicrobial organisms were eliminated from the study because it's only FDA approved for monomicrobial. One unique thing was that sometimes the MALDI was able to detect if a bottle, was a polymicrobial. It would list it in the identification section that, it might be a presumptive mixture. And that was pretty interesting too to look at when viewing the report. And this was the products that I discussed in this webinar session. Thank you for listening, and I am open to any questions at this time.